I want to say hello to everybody, and this platform does allow us to welcome people from near and far, so I'm sure we have lots of other people calling in from other places, but I see Ken Adderman, past president, who's now in Memphis with his daughters and family, and we're very happy to be able to welcome people here. It looks to me like Steve and Norm are in Tahiti, I don't know where far. And to welcome you to this conversation, which I'm particularly excited about. As you know, our series From the Front Lines, the conversation about COVID, has been very interesting and has allowed us to showcase the expertise of many of our congregants and people who are connected to us, who are out in the world doing wonderful work that happens to be at the center of news at this moment in time. And I feel very happy to admit Susan Faust this very moment to this conversation, whose son, Dr. Jeremy Faust, is back with us again tonight. He was here, he was our second guest in this series at the beginning of May. And his style, conversation, writings all over the American press were of great interest to people as we were just beginning to understand or ask questions at least about the pandemic. Maybe we'll never understand it, but we are delighted to be able to have him back with us tonight. He's here briefly, but normally is living in Boston as a professor at Harvard and an epidemiologist, looking at this pandemic across the country and across the globe and trying to help us understand it. So he will be interviewed again by our very own Dr. Jonathan Graf, who has wonderfully agreed to host these and to bring our conversations into kind of a combination of medical and lay people's terms so that we can all understand this high-level conversation about what's going on with this pandemic that seems not to be ending. And as I said to Dr. Faust a couple of minutes ago, what I really want to hear about is when kindergarten will start. So that's the most important thing I need to know. And I will turn this over now to Drs. Graf and Faust with an enormous thank you to both of them for being with us again tonight, and to all of you for tuning in.
So thank you, Rabbi Graf. It's a pleasure to be back with all of you again today. I think our guest this week really needs no introduction, since he was introduced almost, I guess, more than 2 months ago, and was in fact amongst this series where we've had some wildly popular speakers. Dr. Jeremy Faust, by far and away, has been our most popular speaker, at least judging by the responses that we've gotten so far. So we thought we'd invite him back now that the pandemic of COVID-19 has had a chance to evolve and grow over the last, and morph into something we all feared, I think, over the last couple of months. So we thought it would be a good idea to bring Dr. Faust back. Dr. Faust is an emergency room physician, emergency doctor, and professor at the Brigham Women's Hospital at Harvard Medical School, who's developed a unique interest. I guess I described you before as a theoretical epidemiologist, someone who I think is very provocative and certainly using good data and good logic, probes and prods, and I think awakens both the medical and lay communities into understanding, I think, the realities of, in fact, what has been going on. And I think, not coincidentally, he has become one of the leading experts, I think, in the country, trying to both study and explain this pandemic to all of us. So with that, welcome, Dr. Faust. Jeremy, welcome back to our session. Thank you so much for doing this.
You could remind everybody to throughout the conversation.
I think you said that, didn't you? I think, but welcome back to the congregation you grew up with, Jeremy. It's a pleasure to have you back, and I have to agree that you are also my favorite interviewee, I think, as well, both for your intelligence, your engaging, and your thought-provoking way that you've approached, I think, the issues of the pandemic. So welcome back.
Thank you. It's the first popularity contest I've ever won.
Oh, I think we need to unmute you here from.
I'm good.
There you go. Now I can hear you.
Okay. So I was just, thank you. And it is the first popularity contest that I ever won by far. I think it's the first one where I didn't come in last. So there are so many things about this pandemic that are surprising, and that's got to be up there.
Well, I think I'll get you started by pointing out how prescient you were, both when we talked back in May, in relating to some of your writings back then. I want to bring into perspective here something that you wrote about first. You wrote about testing and the need and what testing is all about. This is what, when I first read some of your pieces, this is what rung the truest to me, and something that I had been arguing about from the beginning of the pandemic when I was sort of slogging on the medicine wards here in San Francisco, complaining about not just the lack of testing, but the way that we were testing people. And you really wrote that there are 3 reasons to test. This is something you wrote back in March, basically, that there are really 3 reasons to test people. One reason is you want to test people because they're symptomatic and you want to diagnose the disease, and that's clinical testing. The second reason you would test people would be because you're trying to drill a hole, so to speak, looking for oil, right? You're trying to do random sampling of the public to get a better idea of what the true prevalence is of a disease in a broader population that you don't have the capability of testing everybody for. And then the third reason you gave for testing was really interventional testing. And I think it's one of the biggest frustrations that I've found, I think, clinically right now, is that we're still really in mindset number 1. We're still pretty much using our testing capabilities to test those people who are symptomatic to diagnose them with this disease, even though we're sitting in July and people who come down with flu-like symptoms in July probably have a very good likelihood of having something like COVID-19. But instead of using our testing resources to go after the invisible enemy, which is the asymptomatic carriers who are basically responsible for spreading this disease all over the country and perpetuating it. Can you comment to that, and as to how this may relate to our the mistakes that we made, both in our initial response to the pandemic and in our probably hastily reopening of various parts of the economy?
Yeah. Testing is a major problem, and it continues to be so. And it was early on in the pandemic that I wrote about testing for the first time, and it was in a moment both of a little bit of fear, like, oh, this is a real thing, this is really going to be a problem, but also it was early March, where I felt like there was still time to address this, that we actually had a moment of political will and interest in actually staving this thing off. And I felt like what I initially wrote in March was, we need to test every American as often as possible. And we basically just need to be the great testers. Like, that's what we need to do for all the reasons that you said. During there's really several points of having a shutdown. And surprisingly, it's not necessarily to save lives. I mean, we think it is, but actually the real reason the epidemiologists made the argument for a shutdown at first was to buy time for 2 reasons. Number 1, for hospital capacity issues. Let's imagine that every hospital can save 1,000 lives in a certain unit amount of time, but if you are overrun with too many patients at once, then you're going to lose lives you would have saved because basically you had too many cases at once. So flatten the curve, that's what that is. And the second reason, but it doesn't necessarily say you're going to actually save any more lives than just that issue, that sort of, when you reach your capacity, if you could save 1,000 lives, but then you had 1,050 people, you only save 50 lives, which is not bad, but it's not like the 1,000 you saved. The second real reason to have a shutdown is to buy time for an infrastructure like testing. And we squandered that in a historic way that historians will marvel at with large eyes. They will say, how could they have shut down in March? How could they have declared a national emergency on Friday the frickin' 13th of March, 2020? And come July 28th, the best way to get a test for coronavirus in this country is if you happen to be on the New York Mets. Because the way to get testing right now, essentially, if you're out there, is to be a Major League Baseball player, or to be a football player, or to be in sports. We have prioritized our society in such a way that this is the situation we find ourselves in. So as I've done a couple of times, because I think that probably artificial intelligence will be able to transcribe all of these conversations and the historians will look back on it. I just want to say the keywords like time capsule and future historians. We know what we messed up here. We are phenomenally aware of it, and it's very painful. So that to me was the major thing that we failed to do during the shutdown. Then you flip back on, well, this realization that I had, I guess probably shortly after we spoke in May, which is we're never going to do it. We're never going, this country is just too stuck in its thought process to test every American. And so what we need to do is to acknowledge that and to respond accordingly. And the way you do that is to say, okay, forget it. We're not going to test everybody, but can we at least test intelligently? And by that, I mean, not just willy-nilly, people come to the hospital and they have a symptom and they get tested, and not right now who gets tested and why is really quite random. It's just, there's no system in place. So if we're going to do that, we're going to learn nothing as a society. What we should be doing, is what you said, is assuming that every single person who has any symptoms has the virus. Just go ahead and assume that. And basically only test people with two features. Either they have no symptoms and they have a lot of community contact, grocery store employees, people who are working on the subway, people who, if we don't catch an outbreak there, they could spread it to a lot of people. And the second group of people well, that's the main one actually. But the other group is just basically to do kind of like a random sampling, almost like the way you do like a Gallup poll. You don't just go to the supermarket and stand outside the supermarket and say who you're voting for. There's a scientific method to how they do polling so that you know, okay, these 1,000 voters we got is a really good representation of, you know, this state or this city or whoever it's going to be that you're looking at. And so you do a statistically valid poll in a way and you use tests to say, okay, what's the prevalence? That's the two major ways. The other way, and then the exception to this, is that you still have to test universally nursing homes, prison populations, people who can't advocate for themselves, people who are stuck in situations where an outbreak needs to be detected before it becomes like a wildfire. So I wrote this up with Harlan Krumholtz, who's a health outcomes researcher at Yale University in I guess in May or June. And since then, Harlan and I have begun, you know, what they say, a beautiful friendship. We've worked on a lot of different things together, kind of studying this pandemic and what it means and what we think is happening on the ground.
I think that's spot on. And I think I even would add a couple things further. I think what's really struck me is, I mean, if you look at the inability of people in this country to simply wear masks, right? Part of the deal with testing asymptomatic people in this country, I mean, the ultimate way to really have expanded this during the critical time we didn't would have been to have developed, and they have developed, they just haven't been released, home testing kits and other less invasive self-administered testing kits where people at home could basically be surveilling themselves on a regular basis, sending it in to see if they're symptomatic or not. And you know, if we were a responsible country that actually would test, where everybody would test themselves whether they're symptomatic or not, and B, more importantly, quarantine themselves if they were. I mean, you know, it's remarkable to me that we used to send people off to sanatoriums, you know, without, you know, the drop of a hat, you know, 70, 80 years ago, if you had tuberculosis or leprosy, you were shipped off to Molokai, for example, you know, if you had leprosy. But, you know, because people, God forbid, wanted to catch something like tuberculosis. But here you have this pandemic going on all over the place, and people, you know, won't self-isolate. I mean, our mayor, London Breed here in San Francisco, was furious last week because a person who knew that they were COVID positive by swab, nonetheless, later that day or within a day or two, went and met the mayor in person here. And she couldn't fathom how somebody could knowingly do that. And I think, you know, part of the issue of testing everybody really and doing it effectively would, I think, in part require people to do it themselves with some responsibility, and then take the responsibility if positive to stay away from people for 14 days. And I think that would have done a lot to knock down the proliferation. So I think
there is research now to suggest that home testing is valid. Even self swabs are fine. You don't have to. They did that at Stanford. So there's a lot of ways to lower the threshold. I think that pool testing is an idea that really it's just a simple idea, but just for the viewers, if I live with 5 people and we actually just all take 5 swabs, which you just need 5 swabs, and put them into one test. And the idea there is you only need to run one test for 5 people. And so if the rate limiting step, if the supply issue is the test itself, the reagents or the machine, then you test 5 in 1. And since we all live together, if I'm positive, then we have to assume everyone else is, and you're done. And then you can also do, which is really brilliant, you can do like a matrix. I don't know if you've thought about this. So you can do 5 here. So like here's a row of 5. This is me, my wife, my kid, my parents. And then you also run that, if that row is positive, you also you can actually run pool tests on in the vertical direction. So, okay, we're going to run just 10 tests, and we'll actually isolate who the person is or who the people are. So there's really, and that's been validated. So there are great ways to save money, to save time, to identify people in a useful way, right? And that's the real shame, is we haven't done that. To your point about people taking personal responsibility, I think that is a major story that's being told. And for those of you who have read The Great Pandemic by John Barry, which is this book about the 1918 influenza, the H1N1 influenza, which everyone calls Spanish flu, even though it probably came from like Kansas. But I think one of the great parts of that book is the last chapter, in which Mr. Barry prognosticates what he thinks might happen in a modern pandemic today. And he's writing this like 10, 15 years ago. And he gets an extraordinarily large amount of it correct, including how difficult it would be for us to change our lifestyles. So in 1918, people were not going out to dinner all the time. There weren't business dinners. There wasn't travel for work. So basically, a quarantine was a 20% adjustment off of your regular life, whereas today it's actually a big deal. Not to say that we shouldn't do it. I mean, good Lord, we need to do it. But he said, I'm not sure people will go with this. It could be a major problem. So our own cultural sort of progress, or our own culture, it may be working against us.
Oh, I think that's absolutely right. I think, maybe it's easier for Germans and German culture to do it, for example, than it is for Americans to, who are so interactive and mobile and traveling around the country, and the way we do business. I mean, part of why we're so successful, I think, economically, is in part that same culture. And then maybe that's the same culture that's worked against us, in the setting of the pandemic. You wrote some very prescient things. We discussed this in the last time we were talking about the equating of the SARS-CoV-2 pandemic to influenza, and how you and I were remarking about how we've seen very, very few people die of influenza, but we've seen lots of people die of COVID-19, and how the CDC inflates the numbers for influenza and such. And one of the quotes that you made in one of the articles that you have since published, at that time, mind you, this is now going back several months, was that you felt that if public health officials misread the CDC data and equate an apple to an orange, and basically equate the number of deaths reported to COVID-19, which are actual deaths, to the CDC's number of deaths for influenza, which are inflated 6+ times probably over what the actual number is, where the actual COVID deaths in the week, I think you were citing back in March or April, whatever, were like 16,000, whereas the number of influenza deaths would be like 300 or 400, for example, during that week. But if the government leaders misequate those data, they may reopen too early, or based on false knowledge. That plus a whole bunch of other things probably have resulted in a very faulty reopening of the economy, which obviously needed to reopen, but there probably were more intelligent ways to do that. Can you speak to a little bit of where some of the successes and failures have been, I think, in our quest to balance economic survival with sort of the necessity to thwart the pandemic? And I, a lot of people have been very quick to jump on states like, Florida, Texas and stuff, but our own state in California has been very guilty, particularly in the Southland, where a lot of patients now are here up in San Francisco getting treated because of overwhelmed hospitals in Imperial County and in places in the South. We clearly have done things wrong in this state too.
So the broad picture of what's going well in the United States is very little, but we are one big species. So what I'll do is I'll just sort of remember that we had these bonds with the United Kingdom that we decided to tear asunder 230 years ago. And the Brits have done a remarkable job with research in a way that we ought to be extremely jealous of. And in the future, we should plan to do what they did, so that if and when this occurs again, we can actually replicate that and be leaders. And what I mean by that is they have organized on a national level how they're doing their clinical trials. And so they are being it's not sort of one group competing with the next, different hospitals trying to figure out what to do. It's organized. And so they have a group called the Recovery Group, and they studied, these are randomized controlled trials. So people are actually going to either get placebo or at least the standard of care, or they'll be randomized to get whatever drug that they're looking at. So they looked at dexamethasone, a very inexpensive steroid. They looked at hydroxychloroquine, which of course has been in the news. And these are high quality trials that really give answers. And dexamethasone looks like promising. I'm still a little bit concerned about the data being a little bit maybe overplayed, but it looks promising. Hydroxychloroquine, as I think many of us now know, is a dud and is pretty much only continuing to be discussed because it's a political hobby horse, and it's become this weird litmus test wedge issue, which is a whole other cluster. But so we've done well, I think, is as a society, is we've kind of gotten our mind around the biology. We quickly understood what this disease was, how it spreads. We picked up the fact that it spreads with symptom-free disease, which is, I think, is a really unexpected finding. We're developing therapeutics. I think that the vaccine trials that are coming out, I'm not a vaccine specialist, but I've been talking to people who are, and I can read these papers myself. And I'm sure, Jonathan, you can tell me more. But what I've seen so far is I've yet to see anything on the vaccine side that says, oh, we're in trouble. I'm not saying that we have found anything that's a shoe-in, and that, okay, that's the thing, and we're going to do it, and it's all over, and everyone just chill, and we're fine. But what I will say is, every time we hear anything, it's kind of positive, and there's not much to scratch your head out and say, nah, they're flubbing it. So I think the science community has done a really remarkable job, by and large, of just 6 months into this thing, or whatever, having some therapeutics, having vaccines, and so that we should be congratulated on. In terms of understanding the sort of non-pharmacologic interventions, which is the fancy way of saying changing your behavior, we're not doing very well. I think that what I'll say is some of it, point to blame and say, okay, these places they opened too soon. And that's all well and good. One of the things I'm studying now, and it's too soon to talk about what we know, but we're trying to really, really get at what works and what doesn't work. And this is an area where the science has been pretty bad. So there's been a number of studies that come out that said, oh, look, here's our cases, they're going up. And then we did a mask mandate. And then look, lo and behold, the numbers come down. So it must be that masks are working. Well, those studies have not been very well done. They're poorly controlled. They don't account for the fact that mask mandates tend to reflect how people are feeling locally when they get it. So they stop going out, and when they do go out, that's 90% of it. And they okay, fine, they'll wear a mask and they'll wash their hands. So what I'm trying to figure out with a group at Yale and Texas A&M and at Brigham and Harvard is what's really driving case spikes. And what I'll tell you is there are certain behaviors that appear completely fine. And I want to put that out there because there is this notion that we should just shut everything down, hunker down, and start over, which I think it's a nice idea, but it's not going to happen. But there are things that are safe. You look at Google data for how many people were at the park, literally parks. They can actually track that with their maps. And after the shutdowns or during the shutdowns, park data, okay, people go back to local parks, no correlation to cases. Going outside to the park is fine. And people, oh, your mask is over your chin, you're not putting it over your nose. I'm not so worried about that because we see that mostly outdoors where it's pretty much not probably unlikely to be helpful. So what I'm getting at here is I think we're just beginning to know what really matters. And I think probably, as you suspect, it's anything that's in very tight spaces for long periods of time. And so that's why indoor dining is such a disaster. We hear these cases, right? So I think that what we're doing well is we're learning about what to do. What we're doing poorly is we're not applying it. So I think that is the opportunity, if not for this crisis, then for the next one.
I think that's exactly right. And I think to get back to the point you made earlier, one of the reasons for shutting down initially was when we didn't know these characteristics, it gave us time to begin to try to sort these things out and figure out what we do know, what we can learn about. And I think you're right. I think, the way to reopen the economy, in my opinion, would have been to reopen all the things that could be done with plenty of space outside, as well as individual stuff, 2-minute encounters inside or whatever, but to have stopped the things like parties, indoor dining, church services, and I mean, these are obvious things that I think, Memorial Day, large Memorial Day gatherings, July 4th gatherings, things like that I think, and family here in San Francisco, at least with some really good, we still do contact tracing here, luckily, because the case rate has been relatively subdued enough that we've been able to do it. And it looks like when you trace cases, there are two, and Mayor Breed talked about this last week, there are two large groups that rise to the top of people getting COVID here. And number one, it's people going to family gatherings. thinking they're safe because of the high asymptomatic transmission rate that we'll talk about in a second. And two, it's essential workers working in indoor spaces. Just what you're told, who have to go work in restaurants and have to go work in other, and I just think it would have been so easy to have left the movie theaters out, for example, in this state, which we didn't do, instead of opening the movie theaters, and we'd probably be in a lot better shape if we hadn't done that.
Yeah, the more I think about this, and there's a guy at Georgia Tech, Joshua White, is a great risk calculator. He says, okay, how many people are in the room with you and where are you located? And then he takes the case counts in that area and says, okay, here are the odds that you're in the room with someone who has COVID. And that's really important to know that, right? And so I kind of almost feel like it's like allowance. Like everyone, you should be able to, in every location, say, okay, look, Jeremy, you're in San Francisco right now. The caseload is this. If you want to be safe, you need to interact with fewer than 100 people this week. Now, be careful how you spend those 100. I don't think you should spend all 100 in a 5-meter squared room. But by and large, that's how to think about it, is that you sort of have an allowance. And if you're just constantly going over and over and over, that's when we get into trouble. Because I went on like CNN and they were like, they wanted to do this thing with like, we're going to list, can you go to this kind of thing, a pool party? And can you go to this thing, it's outdoor bar? And they, yes, no, yes. And I was like, guys, you're missing the point. There are types of behaviors and types of situations that increase your risk. And there are types that don't. So the pool is fine. I don't care about the pool. Like the chlorine is fine. The issue is the bathroom at the pool, right? And so going to the beach and swimming or going to a pool that no one's at is fine. The issue is then you go inside of the snack bar. And so, but I think the real take home that I think would be a simple way to roll this out would be to sort of think of it as an allowance. Like here's the number of people that it's safe to interact with. There's no silver bullet, but that's how I think.
Well, I tell people I liken it to drinking milk, right? I mean, think about that. I mean, if you smell, if you take a milk out of the fridge that's been there for 6 months and it smells horrible, the inoculum of bacteria in there is probably so high that if you chugged it, there's a much higher chance that you're going to get sick from that than if the milk was just starting to go bad a little bit with a much smaller inoculum of bacteria. I think, if you just think about it, you need a certain inoculum probably and a certain exposure to get up to that inoculum and a certain immune system. And everybody wants a yes or no answer, a black or white answer. Will I get infected? Will I not get infected? And I think people in this country have a very difficult time dealing with uncertainty and being able to say, I can't tell you 100% yes or no. I can just tell you that the more virus you're exposed to in over more time in your vicinity, whether it gives you a higher chance of getting infected. And if you wear a mask, that cuts down someone delivering the virus to you and vice versa, then that gives you more time and more exposure. But it's not infinite, and I think people have a very difficult time figuring out what to us is really common sense about how infections spread from person to person. So, so I think, this sort of gets, now I'll move on to Jessica's something that Jessica alluded to at the beginning, which was the case fatality rate here in San Francisco. And I think part of the reason this has been such a difficult thing to get people to wrap their hands around is that, they hear, there's 15,000 new cases in Texas today and 10,000 in Florida, and where are all the deaths? And even though these states, the hospitals and ICUs in these states are completely full, and even though there are people dying at a much higher rate in July of a respiratory infection that you would ever expect there to be normally, people are having a really hard time fathoming this. And you wrote once about part of what's so difficult to glean about death rates in COVID is that you don't really know what the denominator is, right? In order to understand what the case fatality rate is, you have to know like what the true prevalence of how many people are actually infected with this. And when we talk about number of diagnosed cases, it's obvious that people who are symptomatic are the ones getting tested. And so you're biasing your algorithm to say like, well, 10% of, in the state of California now, it's 7.5% of all people being tested are positive. But that, and so when you talk about, there's how many cases there are here, it's obviously biased towards symptomatic people. And there's probably, many more people out there who are infected. We've looked at UCSF. I'm doing a study right now looking at seroprevalence of the disease in my patients on immune suppressing medicines. And so far, this is going to be the largest study of its kind, I think, in the country. Up to this minute, we're at about a 15% positivity rate. And I would say the overwhelming majority of these patients, when I query them about whether they ever had symptoms or not, report no. And if they ever did have symptoms, probably they were mild or they were under symptomatic. So more than 90+% of them. So clearly, that's an order of 10 times a prevalence of infection than what we're being told is the actual infection rate right now. So most people who are spreading this disease are asymptomatic carriers. And this is exactly what you were talking about. I was wondering if you could sort of expand on what you wrote about and what can we do about this in terms of trying to understand like why this pandemic is being so difficult to control.
Yeah, so the first thing is that there's asymptomatic, which is you never get symptoms. And then there's pre-symptomatic, which is you don't have symptoms at the moment, but you're going to get symptoms. For the purposes of your question, they're the same because people are running around not knowing they've got it. And that's the real issue. So when you do calculations and we try to do this about what's happening in terms of spread, you have to lump them together. And that's why we have a pandemic, is because of this one thing. But the issue that I think, Jessica wants us to get at, I think, is like why are death rates so different in certain places? And I think it really does come down to what we call an age-adjusted death rate or age-adjusted case fatality rate. The notion that by and large, the case counts are pretty evenly distributed. I mean, a little bit less in the kids, but still about, it's still there, and a little bit more in the sort of octogenarians and older in terms of just the number of people who were diagnosed. But that's not the case with severity. So even though the pie chart's fairly equally distributed in terms of caseloads, we all know from being around for a few months that if you're older, it's a rougher go just on the math of it. So that's the truth of the fatality rates too. And what we don't have, and this is actually remarkable that we don't have this, we in the United States don't have a really good way right now of declaring what our age-adjusted case fatality rate is. So what's the fatality rate for the 20-year-old, for the 30-year-old, for the 40-year-old, 50, 60, all the way up? And the reason we can't do that is that we have the CDC, but they're not the central, they're not like the China CDC who has everything. They have what's submitted to them. It's not, so we don't have a tracking system. So I literally actually asked the CDC, I said, hey, can I get age-adjusted case rates? And they said, actually, we have that, but it's not reliable, but we'll show it to you. And then we'll talk about whether you can use it. So right now, if I want to do an age-adjusted fatality rate, I think my kid is like trying to watch this. This is cool. We actually can't do it. And what I'm almost certain of is that the fatality rate that you detect in any given time is mostly a reflection of who got infected. And so if 1,000 people, we'll put it this way, there was a story I think out in I think it was in the New York Times, about Laguna Honda home here in the Bay Area in San Francisco, and how there has not been a single death there.
That's correct.
Yeah.
There have been cases, but no deaths. That's exactly right.
There must not have been very many cases. And they must have done a nice job of holding that, really clamping that down, because I work across the street from a couple nursing homes that have a lot of vacancy right now. And so because the death rate was just immensely high. So it's really a matter of who gets infected, and that'll tell you basically the infection, what you expect to be the fatality rate. What I think is the next sort of thing that I'm beginning to think about, I'm not going to go in too much here though, is to what extent, how do we get our mind around the fact that yes, the octogenarian has a 10 times greater time of dying than someone in their 30s. But what's actually happening with the young people? Is it actually really hitting them? And I'll answer that question in two ways. First is we don't just count deaths in medical epidemiology. We actually count life years. And so if an 80-year-old dies, their life expectancy was probably 7 or 8 years, even at 80. And he gets a 90, it's like 6 more years. And he gets a 93, and it's 5. And there's never a time when you're supposed to be dead already. It's like if you made it that far, you always have a little more time. It's always more than you think too. If you look at the numbers, it's actually reassuring. But things can operate on that. But if you die at 80, you lost 8 years of life. Whereas if you die at 30, at that time, your life expectancy was 85. And so you lost 55 years of life. And so the burden on society, even though it's a 10th of the death rate, is actually not a 10th in terms of the burden of life years lost, both from perspective of how many people are supposed to be alive for as long as they're supposed to be alive, and also in the case of like the young adult workforce, productivity, right? The reason that sub-Saharan Africa has had such a difficult time, if you read Jared Diamond's book, Gun, Germs, and Steel, he'll tell you that you got to have a workforce that's not sick. And if you have a lot of disease, which is you see in developing economies and used to call third world nations, in the young who are supposed to be healthy, you're never going to have an economy that can sustain what we expect in terms of like a safety net. So yes, the older generation is much harder hit and the case fatality rate is much higher. But what an argument that I'm beginning to make is, look, that doesn't mean that we're not having a really unusual impact on young people. And the answer, just kind of spoil it, is yes, this disease is actually killing young adults at an alarming rate, which is something that hasn't really been discussed publicly, but you'll be hearing about that in the coming days.
That is absolutely right. I mean, just to reinforce what you said, and Jared Diamond makes this very strong point in Guns, Germs, and Steel. You're absolutely right. It's one of the reasons why AIDS has been so devastating to sub-Saharan Africa, because it's infected people at the prime of their potential productivity, and you can never build a productive labor force, for example, in those countries that were being literally obliterated by not just AIDS, but by other diseases as well. I would add that in addition, that not only is life years, adjusted life years an important thing, but now there's even a more difficult metric, quality adjusted life years lost. Not only, it's not just death that's the only, metric that's being measured, it's also quality of life. And a lot of young people who get this will tell you months after they've supposedly recovered from the infection, that their lives are not back to normal. They are not productive. They are not feeling themselves. And we don't know what that potentially, if a 25-year-old doesn't die, but it gets out of a long-term hospitalization and ends up being, hypofunctioning for the rest of their lives, that's an enormous amount of lost quality, productivity, however you want to look about it, in terms of their life years, even if they just didn't die. And I think in addition to, if one 20-year-old dies, that's far more tragic than I think if a centenarian dies, obviously, but in terms of quality adjusted life years, even if they don't die, there's a significant blow to the economy. It's interesting, you made this point, and I think it's very interesting, Donald Trump, it's sort of when you sort of writing about the CDC issues that we'll get into here in a second, basically said that we're testing too much, right? Of course, the number of cases are going to go up if we test everybody. And I think he takes great comfort in the fact that the more people that have gotten tested, although he doesn't take comfort in the numbers, because the numbers of infected people look like he's losing, and that we're losing, as America, we're losing the battle. But I think he does take erroneous comfort in the fact that the case fatality rate is the lowest in the world, as he said, because we're testing so many people and we're finding so many low, people who aren't that sick by doing our testing. But the reality is, and how the rest of the world sees this, is that's really bad news, because it's that population of people who are continuing to spread this and infect younger people. And even if a small percentage of younger people are dying, those are people who would never have died otherwise and who are being lost from the population. So you make an incredibly powerful point. And I wrote here on the chat the name of the book, Guns, Germs, and Steel by Jared Diamond. It's one of the best books of its kind to come out, and it's very accessible to the lay public to understand a lot of the big evolutionary questions that he addresses. So in the last few minutes here, I want to get into a very provocative piece that I think we can talk about. It was embargoed, but I think it's going to be coming out in Newsweek, I think, fairly shortly.
It's out.
Okay, it's out. Good. And I think a lot of people here we're in a very politically aware community here, are probably aware of what's gone on, but they probably aren't aware of the details. And this is what I want you to talk about and why it's important. So I don't know how many of you know out there, but I assume a lot of you do, that the CDC was basically fired by Trump. He's fired the WHO. He's now essentially fired the CDC from collecting the aggregated hospital data from around the country. And although the CDC certainly can be blamed for a lot of missteps early in the pandemic, as you point out, I think very beautifully in your editorial, the CDC does do a lot of things right. And one of the things they do is they do a lot of good counting. They're good counters and they're good aggregators of data. And they're very good at analyzing and displaying data for all. One of the things that they've done, and you can explain how this was built, is they very quickly got up and running a national web-based database. It's a voluntary database, but one that was being adhered to very closely. I know the hospitals here in San Francisco were participating in it, where all data on hospitalized COVID patients, on number of ICU beds, number of ventilators, number of sick patients, deaths, everything was being aggregated and sent via this web interface to the CDC, which then made it transparently available to epidemiologists and others around the world. And Trump basically, through the Department of Health and Human Services, stopped that from happening and basically ordered hospitals to report all data to the White House, essentially. And in doing so, I want you to talk about why that's a bad idea in terms of transparency of data, what the motivation could potentially have been to have done that, and what the dangers are potentially for all of us in that particular action.
Yeah, first of all, I don't work for the CDC. We don't always agree on every little thing, but they've been very responsive. The CDC annual budget is $11.5 billion. And just to give you a context, the proposed Space Force, this idea of having like a new military branch that's basically like some kind of like, space-based fighting troop, is $15 billion. So your government wants to create a $15 billion endeavor when the CDC has 11 billion and the WHO, of which we're, so supposedly a dues paying member, they function on 4 billion. Our priorities are really out of whack here. And if you want to understand the economics of this, back in May, the Congressional Budget Office figured that over the next like 9 or 10 years, we're going to have lost $15 or $16 trillion in economic productivity because of this. First of all, they're going to have to revise that. But even that is about 3/4 of a year of economic productivity. So when you want to know how much to spend on pandemic prevention, or maybe even just the idea that like when you reach a pandemic, it'd be great if half the population didn't have diabetes and hypertension, because that'll save lives. The number you have to worry about is it better than $15 trillion? And the answer is, it would take a lot. It's hard. I can't spend that kind of money on the stuff I want to do. You give me like 1/10 of that, or even 1/100th of it, quite frankly, and I will deliver you a really beautifully functioning system that can anticipate problems, that can respond to them, and that befits the ingenuity of this supposedly great nation. So of this once and future great nation, I don't know. At the moment, it doesn't feel that great, but let's hope. So that's the setup. Back in March, I was speaking to a friend of mine at the CDC who was very excited about the fact that they were going to get this module up and running. And this individual has been there for many, many years. It has a very, very good BS detector. Will always tell me when they got it wrong. And this person said, "Look, we're going to roll this out, and it's going to work, and it's going to be great." And it did. And I was kind of blown away, right? Thousands and thousands of hospitals are participating in this. And this matters because if you want to respond to facts on the ground, let's say in the fall, we all see a really terrible situation happen, and things that were beginning to happen in New York start happening more widespread, such as we're running out of ventilators, such as we are running out of hospital beds, such as we are running out of ICU beds. You can see that coming. And through this tracker, because, oh, look, hospitalizations went up. Probably deaths are going to go up in a few weeks, right? So that kind of stuff. So, oh, look, hospitalizations went up. ICU visits are going to go up in a few weeks, because we know these things about this disease. So if you actually want to use data and respond to it, you need data. You need really, really reliable data. And to take it out of the hands of the CDC when they hadn't flubbed it, it didn't really track. It wasn't like, you messed it up again, we're going to take it out, we're going to come and save the day. They were doing just fine. And it was a kind of a feather in their cap, because there were some issues, early on with testing that they hadn't done well. So to have this taken away is I think it takes a big imagination not to be cynical about why they did it. Because giving it to HHS, which is in DC, and it's full of political appointees, and essentially is under the thumb of the administration, doesn't accomplish anything other than basically gives the White House first pass at this information. And lo and behold, there's been a huge deterioration in the amount of data that's out there already. So the hospitals are like, well, we don't know what's going on because the CDC thing isn't being updated anymore. We now no longer have this information. And it seems to me like if you wanted to make the argument in the fall that this whole thing is a hoax and nothing's really going on, the best way to do that would be to say, look at the data. The data don't show any hospitalizations. And how could you achieve that given the fact that we're not willing to shut down, or we're not willing to wear masks, right? The way you achieve that is to cook the books. And so I'm not saying that that's what they're going to do, but when I sit there as just a rational thinker, like, why would they do this? And they did it before they were ready. The HHS might very well have the professionals to do this, although in my experience, this is not what they excel at. This is not their sort of lane, not their niche. So, but they might be able to do it. There's no reason why they couldn't put it together. But why make the transition clearly before they were ready? So it really.
Yeah, and I don't think that the HHS is being chock full of epidemiologists, which is exactly what the CDC is full of: lab scientists and epidemiologists, with very few political appointees at the very, very top. You know, I think you're exactly right. It just, you know, maybe it's more hubris than anything else, thinking that, well, you know, the CDC just puts all this data out there without any editorial input. And maybe a higher maybe it's the arrogance of the HHS and the White House to think that they have a higher intellectual input to make the data before it gets to the public. I can't fathom why they did this.
The irony is that they the way that HHS has it now is actually harder to access. It's harder to make sense of. You can download the data just as you could before, but it's not. There's actually no analysis. So that may be their goal down the road. And again, you know, if they wanted to come and say, look, here's what we're doing better, here's what CDC is doing, didn't do, we're going to do, then I'd be a little less worried. But it just seemed to me to have no real basis in any sort of quality improvement of the situation, especially in the context of these statements like that the president has made about how testing is a sort of bad thing. Again, the case fatality, I just want to respond to the thing you said before, the case fatality rate here versus there, that's just fine shadings. We're all going to, at the end, the final analysis, we're all going to have the same age-adjusted fatality rate, pretty much. That's it. I mean, there's not going to be a big difference. So as long as we keep the hospital capacity issues.
That's it. That's the other answer, I think, to a little bit of what Jessica was referring to. Is I think it's hospital capacity. I think in places like New York, which just got blitzed. You know, and COVID was being treated not just in the ICUs, but in the PACUs and on the floors of a lot of these places where, you know, people were and they were hauling in, rheumatologists like myself to take care of, you know, ventilator management of these patients. Yeah. I mean, you can see where that could potentially get into some issues. Whereas if you flatten the curve and you keep capacity intact, you probably do have overall somewhat better outcomes. I think you're absolutely right. So I think, to wrap up, I think in the last 5 or 6 minutes, let's talk a little bit about vaccine strategy for the country. Let me first, I'm going to share my screen here for a second. We've had a lot of questions about vaccines, and I'm going to get into a teeny little bit of my hope here. I'm more optimistic now than I was a couple of months ago, and I'll explain why. There have been several questions. We've had questions asking about whether the Moderna vaccine, for example, which uses the technology that's never been tested before, but is potentially problematic for that reason. And a lot of experts are concerned, and then other people expressing concern that patients make antibodies to these vaccines, but they may not be durable antibody responses. And we've had a whole bunch of people worried about this. So let me just talk a little bit about the science of vaccines here for just a second. And then we'll end by talking about the public health strategy of vaccines in the last couple of minutes. So let me see if I can share my screen successfully. I don't want to share that. I want to share my email. Let me try this again. Let me close my email here. And try this. 1 second. I apologize for this. Okay, now let's see if I can share my screen. Yes, that's what we'll share. So to answer some of those questions, let me talk a little bit about vaccines in general. So can you see my screen, Jess? Mm-hmm. Do you see the whole screen, or do you see do I have to put it in presentation mode? Let me see what you see for a second. Yeah, so let me share let me do it this way. There, is that better? Okay, so, and you can hear me okay in there? Okay, so the idea behind a vaccine, obviously, is you want to induce an immune response. And there are different wings of the immune system that actually help confer immunity to various types of infections. There's what we call a humoral immune response, which is basically means humors protect you. These are antibodies, usually circulating in the bloodstream. And this is thought to be a particularly effective strategy to defend against respiratory viruses like this coronavirus, where you want to hopefully bind the virus, neutralize it before it can ever get into a cell. But the body also has what's called cell-mediated immunity, which is an ability for the human body to recognize virally infected cells, and in both pathogen-specific and pathogen-non-specific ways, recognize those infected cells through either innate immunity or what we call cell-mediated adaptive immunity, and kill off the cells, destroy them. They're infected with the virus can't replicate unless there's a living cell to live in, so kill the cell, you kill the virus, basically. And in that case, cell-mediated immunity works, and we certainly, it's very effective at both preventing and treating certain kinds of infections. But at that point, the cells are already infected, so it's a little bit farther along in the process. So one of the goals of a vaccine would be hopefully to induce both a humoral immune response and a cell-mediated immune response as well. And so the data I'm going to show here, so there are many, there are 125 or 127 vaccines currently in development. There are 3 that have really come in the forefront lately because they're both far along in their development and have shown significant positive results. One is a vaccine that's being made in collaboration between Oxford University and AstraZeneca. This was a vaccine that we may have heard about a week or 2 ago. Headlines in the news that it produced, it looks like, in terms of antibodies and cells, in humans, both a humoral and cell-based immune response, at least to the virus, but hasn't gotten to the point yet where humans have been actually infected, have been given the virus and then testing whether or not it's effective at reducing the spread of the virus in the immunized people. So that's the next phase of that particular vaccine's development. The second vaccine is a vaccine that's being developed by Pfizer, in cooperation with a German biotech company. This is the vaccine you may have heard about in the news in the last week that the federal government has invested billions of dollars in. And Jessica asked me why, a few days ago, why would the government spend billions of dollars and give it to a company for a vaccine that hasn't been even approved yet? The vaccine may turn out never to work, and you'll have just given Pfizer a nice check for several $1 billion. And Dr. Faust and I will talk about that in a second, about the public policy of going and basically buying as much of this vaccine in development as possible so that they can be produced and ready in time for them to be released if they are successful. And the third vaccine is the Moderna vaccine, which I think everybody's been talking about lately, and this is what a lot of our questions came about over the last few weeks. And I just want to show a little bit of data, because not only is the Moderna vaccine entering the advanced stages of clinical trials where the vaccine will be tested against, there'll be patients given vaccine versus placebo, and then they'll be allowed to go out in the world and we'll see whether or not the vaccine is effective or not. But this vaccine has also been tested in animals, and in particular in Rhesus monkeys, Rhesus macaques, which are very much like humans. And there's actually some clinical data here that I think are very, very interesting. So I'm not going to get into the specifics of how to read a scientific paper, but basically, if you can see my arrow, Jess, here, if you look on the top line here, you can look at the most important graph is here on the right. These are neutralizing antibodies, and the blue line and the red line are the average titers of actual antibodies that can neutralize the virus in these monkeys, basically, at different doses of the vaccine. So this is a 10 versus 100, a 10 times higher dose over here, and you get more neutralizing antibodies. And this is also shown in the bottom as well. And you can look at the ability of those antibodies to actually neutralize the virus. And in patients who actually get in monkeys, patients who get the vaccine, those who get the highest dose make the highest titers of neutralizing antibodies. So it looks like the vaccine does what it's supposed to do. Whether it's durable or not over 6 to 12 months, we don't know yet, but certainly in terms of antibodies, it looks good. If we go to the next slide here, which is not letting me do. There we go. This is actually looking at cell-mediated immunity. And I won't get into what what's actually being shown here, because these are very elegant experiments to go and actually find the cells that recognize the virus itself and look at the cytokines they release. But in terms of the cytokines, in terms of the chemicals that cell-mediated immunity releases that results in good viral killing of cells that are infected with virus, you want what's called a Th1 response. These are cytokines that tell cells in your body to go and basically destroy virally infected cells. So in viral infections, you see a rise in what we call cytokines, in proteins that are released into the body that kill virally infected cells. And you can see that in those monkeys that got the highest doses here, it looks like they make a cell-mediated response that's very effective at killing, that should be effective for cell-mediated immunity, theoretically, to kill cells infected with the virus. And in other cytokines that we see in other kinds of like allergic responses, this Th2 responses, you don't see that same effect as well. So there's cell-mediated immunity, it looks like, and humoral immunity. And most importantly, when you then go and you take these monkeys and you swab their noses for evidence of the virus. You can see it like at day 2 after they're challenged with the lower and higher doses over here. This is looking at lung fluid, and this is looking at nose fluid. You can see that the number of the ability to actually isolate the virus goes down, such that 7 days after they're challenged, there's basically no virus detected in these monkeys at all, either in their nose, and almost the entire time there's almost no virus detected in the lungs either. So it looks like the virus is effectively prevented from replicating in these monkeys as well. And again, these are data that just came out yesterday in the New England Journal of Medicine. And more importantly, when they sacrifice these monkeys to look at their lungs, and I'll just highlight you down here, this is looking at the actual virus itself, and that's these colored things you can see here in the lung tissue. In unprotected monkeys, the virus is all over the place in the lung, but in protected monkeys, which is up here, which are these 2 doses over here, the 10 microgram and the 100 microgram dose, you don't find any viral particles in the monkey's lungs at all. So it looks like, both in terms of antibodies, cell-mediated immunity, and in actual pathology in both the nose and the lung, it looks like this vaccine response, at least in monkeys, protected them from a direct challenge to the virus. So for those of you with sort of concerns about whether a vaccine may or may not work, we still don't know. There's a lot still to do. Let me unshare my screen here. Is my screen unshared, Jess? Okay. We obviously don't know, but at least as far as we can tell scientifically, at least in the animal models, which is very, very good, and in terms of the initial phase, early phase clinical results showing not that much toxicity, it looks like we're on a good track, and I have some optimism here. So now let's end in the last couple of minutes here to talk about the public policy behind this. People have been concerned, for example, that with these emergency use authorizations and such, that the FDA has dropped the ball, is sort of letting anybody and everybody develop a vaccine. There's potentially a lot of concerns for safety. The FDA has set a benchmark of 50% efficacy to determine what they'll actually approve a vaccine for or not. I would argue that I think, and everybody's worried that somehow there's going to be an October surprise, that Trump's going to come around in October and basically rush one of these things to market, saying that he's the champion of this and reelect me, I saved you from coronavirus. I want to get your perspective on this. And from my perspective, I think a 50%, the idea of a vaccine obviously is to protect us, right? But there's also a risk-benefit ratio here. If a vaccine has no toxicity, but protects even 20% of the population, that to me is worth it. And when you set the benchmark at 50%, again, you love seeing 50% protected, but the idea is also to prevent further transmission and herd immunity, down the pike. And if you can protect 50% of the asymptomatic carriers from getting infected and spreading it around the country, the pandemic curve is naturally going to flatten just from that alone, even if it's not a 100% effective vaccine. So I think that the strategy of going out and buying these things in advance and taking a chance, what's a few $1 billion to this government, right? As you pointed out, to the Space Force, they're spending $15 billion to something that doesn't even exist. What's a matter of a few $1 billion to buy the vaccine, make it several hundred million doses of this so that it's ready to go if there's any positive signal here? I had no problem with that, but apparently it's very controversial, and I wanted to get your thoughts on that.
Generally, there's been a lot of controversy over the years about governments buying up things that they don't need. The United Kingdom got in a lot of hot water. They bought oseltamivir in large amounts, which is a drug that is supposed to help with influenza, has a very poor record of doing anything much other than making you feel sick. And so I agree, in pandemic times, there's little downside. I think that it's fine. By the way, I read that article that you showed yesterday morning. I got an embargoed copy of it like an hour and a half or 2 hours before it came out. And I was trying to read the thing, and I was very gratified that what you just said is almost everything I understood. So I feel very, very validated right now. But oh my gosh, oh, this is complicated. But on the policy side, I think that the economics of it, I don't think I'm equipped to answer. But what I am more interested in is this notion of, will people take it? And this, you see all of these fearful statistics where people say, well, I would think about it, or well, wait and see. No, I'm not going to take it. And this is one area where I'm actually optimistic about things. And also, so I'm glad we're ending here, with respect to both the American people and also with the statistics of what we need to accomplish, and also with our colleagues, physicians. So number one, I actually think that we have a pretty good set of research about vaccine hesitancy. That is the fancy word of saying not anti-vaxxer, or that's sort of how it's sort of couched. So, and it turns out that that interest in vaccines waxes and wanes in a kind of a predictable way. And it makes sense when you think about it. When there's an outbreak of something in your community, in a community, let's say, that has a lot of people who are not so into vaccines, of course, that's why there was the outbreak. But when that outbreak is over, suddenly interest in vaccines actually goes way up in that area because it hit home. And so there's this opportunity. So there are models that say, look, a disease happens and it spreads like wildfire, and then it's controlled. And basically the second time it kind of breaks out, the second time, that's your moment when you can really knock it down because there's interest in vaccines and it started from a low enough level. So that's another reason why we should be flattening the curves. We want to be starting in a place where we can control the thing, for number one. And so I actually think that despite these polls that say, oh, I won't do it, I will or I won't, I think when push comes to shove, there will be quite a lot of interest in that. And as you said, we don't need 100%, we don't need 90%. First of all, by the time it comes out, about a third of the population at least will have been infected with it. We'll be halfway to herd immunity anyway, unfortunately. And then other people, and then, well, I mean, we'll see if the antibodies last, but let's assume that they last in some meaningful way. So, and then you really don't have to get everybody. You have to get enough people. And I think that in the most vulnerable populations, we're certainly going to have a lot of uptake. And that brings me to the next, the last part, I guess, which is that in my experience, when I've talked to patients about why don't you want to have this treatment or why don't you want to have this vaccine, this conversation happens all the time. I think that this is where some of the medical training I think we got was good. They actually, at least when I was going through medical school and through residency, we were trained to sort of listen to the patient, and it wasn't like, okay, it's 1950 and I'm the doctor and you do what I say. It was, you're going to have people who Googled one thing and now they're Dr. Google, and now they're going to tell you what, more about your business than you know. How do you deal with these people instead of saying, no, let me just tell you why I'm the expert and you're the idiot. No. So actually, we were taught to have this sort of like open-minded kind of conversation. And what I think it does is it invites people to air their concerns. And then if you know what you're doing, which I think most of us do, who are doing this on a daily basis, you say, okay, look, that is a completely rational concern because you probably heard this and this, but here's what's going on. And what I find when I do this, whether it's a vaccine that we offer, during screening, or it's a treatment, is the hit ratio, the people like getting from no to yes is very good. I mean, I'm not going to say I'm going to convince every single person, but it is well more than enough that I think that we're going to get there. To me, the big difficulty, I think, is going to be the infrastructure. So up until now, there's been a real reluctance by the government to use its authority to make tests. And so I hope it doesn't persist when it comes to making the syringes or the vials. I don't think we need to reinvent the wheel in terms of where this rolls out. My vision for where the vaccinations will occur mostly is pharmacies. I mean, look, every single pharmacy in this country gives flu shots. They have the infrastructure for this, and people are used to going to the pharmacy for their flu shots. And on top of it, pharmacies actually are a really wonderful way of measuring the needs of a community. So if there's one pharmacy in a town of 10,000 people, that's what you need. If there's 5 pharmacies in a 10 square block radius like there is in New York, that's because there's a lot of people there. So pharmacies tend to have a supply-demand thing so if you want to know, gosh, how many testing centers should we have? How many vaccination centers? The answer is right before us. It's pharmacies. And so that's a beautiful situation that I think, again, it's the one sort of example of a private infrastructure that kind of in a weird way mimics a public infrastructure in countries that have universal healthcare. So that's my hope, is that we'll do it in that environment. Plus, of course, the usual way is the doctor's office and the hospitals.
Yeah, no, I think I agree with you. I think the other infrastructural thing that'll help will be like an ID card that has a vaccination record, like you do when you travel to Brazil, or I guarantee the EU and other countries will require proof of vaccination as well. And if you're not allowed to get into an NFL, football game or go to a movie theater without proof of vaccination first, I think that'll motivate people to get vaccinated, I think, as well. So again, I want to thank you so much, Jeremy. It is so engaging to talk to you and to interact with you both as a professional, as a fellow professional, but just in your ability to explain things in such, I think, very descriptive and easy to understand terms for everyone. So thank you very much. I have truly enjoyed this as much, or if not more, than even the first time we did this as well. So
yeah, I love the long format. I love that. It's like in the Oscars, they're gonna play you off or go to commercial
right.
break.
No music is going to send you off the screen here, right?
The long format is great because you can explore ideas, and I appreciate the questions and the forum. So thanks so much.
Thank you.
And I want to add my thanks. I hope you'll. Let's see, we're echoing. I hope you'll be back with us in a couple of months to tell us all of the things that we've done right and the magical ways that this vaccine worked out, and that we've prepared ourselves for any future pandemic should this situation arise again one day. So a huge thank you to Drs. Graf and Faust, to Leland and Susan Faust for having two awesome sons, one of whom has been with us today, and to all of you for joining us. I just want to give the last word to Gordon Gladstone, our executive director, who is here and wants to thank everybody for joining us. I think he's here. Gordon?
I think I'm here too. Let's see. Oh, there we go. Here I am. Indeed, I am Gordon Gladstone, Executive Director of Congregation Shereth Israel. I want to thank everybody for joining us this afternoon. I want to thank, in particular, our member donors who make these kinds of events possible. And if you're not a member of our community, we invite you to join us, and you can find more information at sherethisrael.org. There are more events coming. If you are not already receiving our weekly emails under the dome, you can sign up for those as well on our website. Again, thank you so much, and we look forward to seeing folks Friday night for Shabbat services, and have a great evening.